Yes, my name is Nupur Singh. I'm a second-year medical student here at UT, just to introduce myself today. And here we have a rare case of Mycobacterium conceptionense infection in a post-renal transplant diabetic in the Southeastern United States here in Memphis, Tennessee. So this mycobacteria is also known as a nontuberculous mycobacteria, and those infections have been steadily increasing at an alarming rate of 8.2% for pulmonary infection annually for those over the age of 65. However, on the contrary, tuberculosis infections have been on the decline with improved drugs, mandated public health reporting, and better treatment responses. So with non-tuberculous mycobacterial infections following the opposite trend, it's really important to look at research for markers of early diagnosis, as delayed diagnosis results in much more complicated treatment. Those particularly susceptible include elderly people, women, immunocompromised, patients with HIV, and those on immunomodulatory drugs. Mycobacterium conceptionense is one of these non-tuberculosis mycobacterial species, and it was first isolated in 2006 from a post-traumatic osteitis inflammation in France. Mycobacterium conceptionense is a non-pigmented rapid grower mycobacterium that belongs to the Mycobacterium fortuitum group. Only a handful of cases in current literature exists with this particular kind of bacteria. One case was in face rejuvenation surgery and fat grafting, while another was a septic infection in a patient with advanced gastric carcinoma in Japan. Other cases include pulmonary infection and a subcutaneous infection after breast augmentation surgery. Now, while most non-tuberculous infections have some global trends in regard to the environmental factors that make them more prevalent in one area or another, this mycobacterial species has an unidentifiable pattern of regional bacterial prevalence, as has been reported in nearly every part of the world, but still only 20 cases have been reported in current literature. So this case adds to the limited availability of Mycobacterium conceptionense infection and presents with two main risk factors in this patient for infection. One, a prior renal transplant, and two, insulin injections required in subcutaneous tissue. So to date, no prior cases have been reported on an organ transplant patient or in relation to subcutaneous insulin injection use, making this case really unique. Also, in the United States, there have only been 2 cases reported, both of which were in the Midwestern city of Chicago, Illinois, again, creating another unique aspect of this being in the southeastern part of the US here in Memphis, Tennessee. So a little bit about the patient. The patient presents as a 70-year-old African-American female with end-stage kidney disease, post-cavadaric renal transplant, and she presented to clinic with a painful lesion as seen in figure 1. She didn't want it to be drained with local anesthetic, so we performed an OR procedure under anesthesia, and drainage was completed with no significant complications. The results were then immediately sent for testing to figure out what kind of bacterial infection it was. 8 years prior to her presentation, she underwent that renal transplant, and the patient's past medical history is incredibly complex. Diagnosis at the time of infection included obesity, insulin-dependent diabetes 2, hypertension, hyperlipidemia, lupus, pancreatitis, cerebrovascular accident, sleep apnea, and coronary artery disease. She also had an extensive surgical history, making this patient very unique and very complicated. After the abscess was drained, she was immediately started on empiric antimicrobial drugs awaiting the susceptibility data. She was started on 100 milligrams of doxycycline twice daily and 250 milligrams of levofloxacin every day, which was adjusted for a creatine clearance. So at the National Jewish Laboratory in Denver, they decided to do 2 main tests to confirm the susceptibility data. It was the 16S rRNA gene and the RPO-B sequences, both of which finally confirmed after thorough testing that it was in fact Mycobacterium conceptionense. They actually ran the test like multiple times because of a variety of mycobacterial infections that came, and since this one is incredibly unique. So the full results of the susceptibility testing can be seen in table 1 on the 4th column of the poster. And as you can see, it's a variety of drugs that are minorly susceptible, but not ones that have like the best, there's not one best option. So in this patient, we decided to keep her on the levofloxacin, on the doxycycline, as she reported nausea and vomiting with levofloxacin. And additionally, due to her increasing creatine, we decided not to use trimethoprim and sulfamethoxazole. Also, augmentin was the chosen, although organism was only intermediately susceptible, but it would be better tolerated by the patient, and we wanted to use multiple antibiotics. So again, before identification of Mycobacterium conceptionense, we were able to rule out all other mycobacterial infections, particularly tuberculosis, and the identification was achieved through those two main testings methods at the National Jewish Laboratory. So in conclusion, this patient presents a unique and delicate case where proper treatment required management of several other medications, comorbidities, and diagnoses. And I'd like to end by thanking Dr. Shirin Mazumdar, who introduced me to the case, as well as my instructors here at UTHSC. And with that, I'd be happy to take any questions. Thank you.
Go ahead.
Yeah, so that's actually what I did my honors thesis on in undergrad. So I'm really passionate about this topic. And I think it's due to the fact that non-tuberculous mycobacterial infections are known to be like less serious compared to tuberculosis. So they don't get as much attention. And they're found in like literally anywhere you can think of in terms of environmental exposures, shower heads, soil, anything you can think of. And as a result of tuberculosis infections being so severe, there's been a lot more research targeted toward drugs that can particularly attack that. Those drugs don't work so well for non-tuberculous species. So I think it's a mixture of those things that are eventually leading to greater research for better markers of diagnosis.
How was the drainage in this abscess compared to, I guess, other abscesses? Was it more pungent or?
It was like known to be like a custard-like purulent kind of drainage. And so I wasn't actually there for the procedure, so I'm not entirely sure, but there was no reported complications. So I think it was mainly like other drainages, maybe a little bit more custardy and purulent, but non-tuberculous mycobacterial infections tend to be about just nothing crazy in comparison.
Any other questions? Thank you.
Thank you.